So, Joe, you've been working in HIV prevention globally for a long time. And I think now we're at a really sort of interesting intersection in the sense of we have lots of tools and we have tools that we know work. But one of the issues we're having at the moment globally is the uptake of those tools. So, from your perspective, what do you think are some of the biggest sort of barriers that we're facing in terms of prevention uptake in HIV?
Yeah, it's so true. We do have many tools, very effective ones, and we have many people and experts in the know-how to bring it all together. And at the same time, access to HIV prevention is uneven. And it goes beyond healthcare issues. It's really about some social barriers that we have, some structural barriers that we have to address. Some key barriers include things like awareness, just having basic awareness of the HIV prevention services, but it's also that there are groups that have an increasing rate of infection, that they don't even know that they're at risk of HIV infection. And that awareness is lacking. So if you lack the awareness of being at risk, then HIV prevention messaging is definitely not relevant. I think there's also another barrier, which is stigma. We have made really good progress over the number of years, especially with certain communities, like the men who have sex with men, MSM communities. And that's excellent in terms of the progress, the awareness, the normalization of conversations. It still needs work in different regions because different pockets of our overall European region is not uniform. And we're at very good levels in certain areas. And at the same time, there's a lot of stigma in others. So we still need to address this. And the example is if a person wants to go in to ask for HIV testing or ask for PrEP options, prevention options for HIV, they may feel fearful of judgment, have shame, and that might stop them and make them hesitate to even ask. And we don't want that. We want to make sure that people who are at risk can feel very normal, and it can be a very regular conversation wherever they go. So that's important. And I also think one other barrier that's really important is service design. So when you think about the delivery of our great options that are out there and new innovations that are coming to different markets, I think it's very important that we think about the communities we're working with. And I call them people. They're not patients. They could be at risk, and they need to learn about being people who are at risk. And again, we've made really good progress with the MSM community. So we have more sophistication, more coordination, more organization. Again, within this community across the region, there are pockets, there are parts of the region that are still under-resourced, or there's still too much stigma, and the coordination of care is not there. But there's also the other group, the other populations where the infection rates are going up. And we need to meet them where they are. We need to learn more about them, their routines, their habits, their insights, so that we can, when I say meet them where they are, really, as I'm, going, would I go to a primary care physician normally for my care, or would I step out to go to a sexual health center or a different type of service out of my way to really check on my HIV care? So it's very, very interesting in terms of the barriers where we've made progress, good progress, but again, significant progress still needs to be made.
Yeah, absolutely. And you talked about access and uptake, which are two slightly different things, aren't they? But in terms of engaging those new communities, so as you said, we've got sort of good establish relationships with the MSM community. I think generally there's quite a good job going on in terms of meeting people where they are, communicating people's risk. How do you, in those groups with emerging rising rates of infection, how do you meet them where they are, as you're saying, but also ensure that you're meeting them in places that they feel comfortable and non-stigmatized in entering?
Yeah, it's a big question.
I know, sorry.
Thank you. I think that we have to, first of all, recognize as a team of, I would call professionals and experts. It really takes a village, to see that, recognize that there are infection rates, there is a reversal in trend in terms of HIV increasing in certain groups. And so that recognition is really key of the entire village, which is of government, of policymakers, public health officials, the community, as well as healthcare providers. And when we can recognize it as a priority and see that these groups need help, then at least we start with some recognition and commitment. I think when we go deeper into trying to understand and identify these different communities, different groups, populations, we have to do much deeper daily life research in, again, their attitudes, their beliefs, their underlying their behaviors every day, their routines, their habits. So every day, what do they do from 9 to 5? Or if it's not 9 to 5, all day long, 24/7. And why do I say that? Why do we need to understand where they go? Because we may not be able to, get them to just go to the conventional ways of accessing both HIV care or also getting tested or getting prevention options. And what we need to do is understand where they go on a more daily basis. So if it's a primary care setting to get care, if it's a women's health hub that they are doing screening, why not meet them where they are so that we're thinking about stigma, we're thinking about awareness, all of those aspects can be somewhat addressed because it's being done in a way that they are accessing care and accessing conversations with healthcare providers in a way that is safer, maybe, that they would think that it's safer, less stigmatized, more comfortable. And that's what we need to do to help to drive access and also uptake.
Yeah, because a sort of thread running through the conversation across the last 2 days has been exactly how do we move from treatment to prevention? And I guess in a way, the field of HIV is leading in some ways in that. So I think there's a lot that actually other sectors and other disease areas can learn from you. What are any sort of key ways in which the HIV community has been able to sort of work together? What kind of interesting partnerships have you been able to put together to help to get some of this sort of aspiration into action?
It's a good question. I believe that we've made good progress, but there still are the barriers that I talked about, which need a lot of work. And again, it requires the political will and the team of experts to come together and really implement and work together. And I can't say that any one of these barriers is, completely overcome, but definitely there is work being done as a team of different groups. And one really good example is Gilead actually partners with the Elton John AIDS Foundation, as well as the Terrence Higgins Trust and the National AIDS Trust. And together within the community, they work on advocating for a new HIV action plan within the UK. This is a UK expansive implementation program, and they're looking at, what are the different levers and what can we do and what can we experiment with and how can we implement to drive more innovation and access to people in need and reduce stigma. So it's again, the idea of coming together, recognizing and doing something together is really important. We also work and partner with NGOs to expand HIV prevention services. And from those types of partnerships, we want to learn. We know that not everything will be right, but we know that, the communities are working within and understanding the people that they're working with. And at the same time, we can have lessons on what's working well, what's not, so that we can replicate and scale in the future. So it does take a lot of work an effort and attention to ensure that we partner widely within the communities so that there is that trust and there is that opportunity to have better conversations and then again meet people where they are.
Yeah, and I think again this is sort of picking up on a lot of themes that we've been talking about across the last 2 days. What do you sort of think that the broader health sector, as we try to move from treatment to prevention, obviously there's sort of issues around reimbursement. How do we recognize returns on preventive interventions? And I guess that's things that the HIV community has already grappled with. So do you have any sort of thoughts in terms of what you, as someone who's worked in that field for a long time, what could you pass on to the sort of the broader health community as we try to move from just reactive treatment-based health systems to more healthy rather than illness systems?
I see that. I see that a number of shifts need to be made. First, in terms of mindset, we definitely need to move from thinking about HIV prevention as a nice to have. And we need to see it move to the cornerstone of public health. And that's very important to bring it into the mix of treatment because it's not competing with treatment. We have to treat, people who have HIV. And at the same time, we have the opportunity to invest in the long run. So I think it goes back to another, there's a point around investment. This is not just a healthcare expenditure. This is not just a healthcare intervention, but it's a financial investment for the long run for public health. And we have to also see that because we actually have a current budget impact model to show that between 2025, which is almost over, to 2030, we have the EU 27 countries, member states. They will likely face costs anywhere between 55 billion to 88 billion euros in terms of just HIV treatment and care, delivery, and services. So it gives us a way to look at how, if we bring prevention into this, that we can help, bend the curve and help over the long run invest in public health. So I think those are really important, and it goes back again to another shift in delivery, in service design. Again, understanding where the infection rates are. They may not be in the conventional space as much. For the first time in HIV history, now we have more heterosexual, infection rates are higher for heterosexuals than for the MSM community. And that means that, there has been great work that has been done to drive the awareness among the MSMs and provide the care and coordination. More work to do, of course. And at the same time, we really need to tackle how to do this service delivery to these new populations and groups. So lots of shifts.
Yeah, absolutely. I think that's a great closing note, is that actually a takeaway from what you're saying in terms of HIV prevention is that it's not in competition with treatment. The two things are still needed. That's the same across all of public health and all of health promotion, and about that long-term investment and things like that. But also as you're saying, keeping an eye on who is at risk and making sure that when we're talking about prevention, we're keeping that up to date with the epidemiology and understanding who's at risk and how that risk presents itself.
Yes.
So thanks very much, Jo, for that great conversation.
Thank you.
Thank you.
Thanks very much.